Hi again, thanks to those who are joining. We're just trying to connect with Dr. Spies, who's the medical director of Vida Fertility based in Spain, to talk all around AMH, amazing topic that so many people have questions about. So please have them ready and feel free to ask her once she joins. We'll be discussing what AMH is, what it means to have it tested, whether you need to have it tested, and also welcome, nice to see you again. We're just trying to connect. It's a great topic, and we have Dr. Spies with us this evening. There we are. Good evening, Dr. Spies.
Hello, good evening. I'm sorry for the
No
delay.
problem. We can't hear you very well. Are you able to turn up the volume a little bit? Okay.
Okay. Can you see me well? Can you hear me well?
Yes, perfect, perfect. Thank you for joining us. And today we're going to be talking about AMH. Before we do, please could you just introduce yourself and your role at Vida Fertility?
So I'm Dr. Katharina Spies. I'm gynecologist and I'm the medical director of Vida Fertility in Madrid. I'm German, so you notice my German accent, but I've been living in Spain
Mispronounce your
since
name.
15 years, more or less. So I'm here for international patients as well as for Spanish patients, but mostly I'm with patients from Germany, from UK, or from France.
Fantastic. Apologies if I have mispronounced your name, not good. But it's good to hear you pronounce it, so thank you. And today we're going to be talking about AMH. So first of all, please could you explain what is AMH? Because we have so many questions around it, as I'm sure you do at Vida.
Exactly. So AMH is the anti-mullerian hormone, and this is a hormone we can use for determining how is our ovarian reserve. In order to get to know the ovarian reserve, we always have to do, or we recommend to do two tests. One is an ultrasound in the first days of the cycle, so after the period, and the other is a blood test, which is the anti-mullerian hormone. This hormone is produced inside the follicles, so in the granulosa cells which are inside the follicles. And the more follicles we have, the higher is the level of this hormone. The good thing of this hormone is that it doesn't, the level is more or less constant during all the cycles. So it doesn't depend on which day of your cycle you do this determination. You can do it in every day, and it's more or less stable. So the more follicles we have, the higher is the anti-mullerian hormone, the better is the ovarian reserve.
Is there a correlation between AMH levels and age?
Yes, most times yes, because the ovarian reserve also depends on the age. So it's true that the better you have the ovarian reserve, the higher is the age. Normally, the younger you are, the better is your ovarian reserve. But we have to say as well that AMH, or the follicular count, is not everything, because the quality of the AMH also depends on the age. The quality of the egg, depends on the age. So it's not the same, the conditions are not the same, for example, for a young woman with a low ovarian reserve than for an older woman, for example, someone of 42, 43 years old with a very good ovarian reserve. The quality of the eggs normally is lower. So we have to have in mind everything: age, follicular count, and the anti-mullerian hormone.
Someone's just asked, what AMH level would you expect for an average 30-year-old?
For a 30-year-old, let me calculate in the English units, because we always calculate with a nanogram milliliter, which would be like a normal value would be around 2. So 1.2 is about, 1.4 is about 10. So I would say between 15 and 20 picomole per liter would be like a normal ovarian reserve for a 30-year person.
Mm-hmm. And people always talk about this kind of number, 35, age 35, and then fertility deteriorating very quickly. What is your take on that?
Not to be too fixed on a number.
Okay.
It's true that we have to value everything, so it depends really on the ovarian reserve. We determine by the scan, by the follicular count, and by the anti-mullerian hormone, because it's true that the scan is more objective, more subjective, and the anti-mullerian hormone is more objective, because it only depends on a laboratory. But you have to have in mind both. So sometimes there are women with a low AMH, but in the scan you see 7, 8 follicles, and then you can have a good number of eggs. And the most important really is the age, because it determines the quality. And sometimes you have women who you only get 3 eggs, but out of these 3 eggs you have 3 blastocysts. And others you get 8 eggs and you get only 1 blastocyst. So it also depends, of course, on the sperm quality and on the egg quality and of how the gametes go together. So.
Okay, great, thank you. Any questions as we go, please do ask. I've just seen one come in now, but before we answer that, I just want to ask you, so that you've explained what AMH is, how is it tested and measured, and is it a test that you have every female patient do when they first come to Vida?
So it's a simple blood test. You can do it in almost any laboratory, I would say. You can do it in any moment of the cycle. It's not necessary that you're fastened when you do this test. So you can really do it in any moment. And yes, we normally recommend it to almost all our patients, unless the patients who are really decided for going to egg donation treatment. But it's a value that gives us a lot of information, and in combination with the scan, because we also ask for the scan for every patient, we can already estimate how many eggs we are going to be able to obtain in the moment of the egg retrieval. And this is good information. Of course, we are not always 100% sure, but it gives us an estimation, and like this you can tell the patients what they can count on or what they can expect.
Mm-hmm. If someone has an AMH level that is not what they hope for, and it's under the sort of measurement that you're looking for an age bracket, should they be disheartened that that means that they need to have IVF, or that IVF might not work?
Well, that's a good question. I would say that a very low AMH level can determine that probably we're not going to have a lot of eggs, and that probably egg donation treatment can be an option, or should be an option. But in the values from low or limit AMH and normal ovarian reserve or normal AMH, you have a big you have a big field, and then you really have to individualize for every patient. So me personally, it's very depending on the age. If someone is more older than 42 or 43 with a low ovarian reserve, I'm going to be clear to say probably it's not going to work. But for younger patients, although they have a low ovarian reserve, low AMH, normally I encourage to at least try once or twice before you change them.
That's good to know.
Depending on the patient.
Mm-hmm. Mm-hmm. And how does AMH affect natural conception as well as your IVF chances?
In natural conception, you have a lot of things that influence. So if there is a woman without fertility issues, or just has not tried to conceive, we normally tell her, well, try for half a year, maybe it works, because low AMH doesn't mean that you can't get pregnant. In women with fertility problems or who have already done fertility treatments, it's true that the chances get lower the lower you have the AMH. But really, only a low ovarian reserve doesn't mean that you can't get pregnant naturally, because we have a lot of women who even don't know that they have a low ovarian reserve. For example, for the first child, and then after the pregnancy they come and they have a checkup, and the ovarian reserve is even lower, but in the first attempt they got pregnant without any problem.
You mentioned that AMH isn't an indicator of egg quality. Do you find that that's a misconception amongst patients that come to you?
Mm-hmm. Sorry, I didn't get like...
When you see patients who have a low AMH, do they assume that means that egg quality isn't going to be good? As in, tell us about any correlation between AMH level and egg quality?
There can be a correlation, but I would say that it's more the age than the ovarian reserve.
Okay.
It's good that when the AMH is very low, so less than 3, for example, it can mean that there's only like the worst eggs left, to say it like this, and then the quality can get lower. But normally, it's more the age than the AMH level, which correlates to the quality.
And what other tests do you look for when you're first evaluating a patient who comes to you at Vida?
So we always have to check both the male and the female partner. There's a male partner. For the male, we normally check the spermogram, which is a sperm count. We have a look at the mobility and the normal forms. And we normally, if possible, we also ask for a karyotype. We normally ask for karyotype for both of the couples. It's not strictly necessary, but we recommend to do it. And then for the female, we have to check normally the uterus by doing an ultrasound, check that there are no malformations, no fibroids, no polyps, anything that could explain why there has not been a pregnancy. And then, of course, we check the ovarian reserve, which is what I told you, the scan with the follicular count and the anti-Muller hormone. And sometimes we also ask for FSH and LH levels in the first days of the cycle. But this depends more on every country, because in some countries it's true that it's more common to check FSH, LH levels than the anti-Muller hormone. I have to say that in recent years it's more and more the AMH that is measured.
Makes sense.
And then it's like the basic exams, and then afterwards we have to individualize for each patient, for each couple, which tests we have to demand.
Of course. We've had lots of great questions come in. May I ask you some of them, please? The first one is, can you improve AMH? Or is it a final figure?
I would say that unfortunately you can't improve it. There are some strategies now, which is like ovarian rejuvenation.
Yeah.
But it doesn't like higher the AMH level. But what we can get with this is a better response to a stimulation. So this is a treatment with growth factors, which are you do a blood test, you get the growth factors, you activate these growth factors, and then we introduce them inside the ovaries. It's like when we do the egg retrieval, but just the other way around. And with this, what we want to produce, or the effect we want, is that in a stimulation in the next cycle, we get a better response to the stimulation. So we activate more follicles. But it's not that we create the follicles, we just activate the follicles that are there and that normally don't react. So really to raise the AMH, it's very difficult.
Okay, thank you for answering that. Another question, someone says that 27, they have PCOS, their AMH is 52. I presume that might be 5.2. It seems high. Or would that be that high for PCOS? I'm about to start IVF. Would you expect her to get a good number of eggs?
Yes. Normally in young patients, young means normally younger than 35, but 27 is really young, with a very good ovarian reserve, with a high AMH, normally, yes, we get a good number of eggs. But the issue in patients with PCO, with polycystic ovaries, can be that quite a lot of them are not mature or are empty. This you can't see in the scan. You can only get to know it in the day of the egg retrieval. And it's also true that sometimes in patients with PCO, the quality is lower than in patients with a standard ovarian reserve. But the good thing of this patient is the age. 27, sorry, normally you should get a good response, a good number of eggs, and you should get a good number of of embryos.
Good to know. Thank you. Yeah, that does that level that they have, which is great. What if one level is low and then another, and then a few years later, it's within a normal a normal range? They're asking what they should try. Do you ever see it rise when it's been lower previously from testing?
Yes, yes. Sometimes it happens. So it's crazy, crazy because we don't know why it happens. But yes, it happens sometimes that the AMH gets lower and then higher again, or the other way around, that the AMH gets lower within some years, but then you do a stimulation and suddenly you get more eggs.
Okay.
I don't know. But normally, the AMH gets lower with the age, and also the answer to a stimulation gets lower.
Mm-hmm. How rapidly would you expect your AMH to drop? I know we touched on that before, but what do you tend to see at Vida?
This really depends on every patient and on the age. Normally, we estimate that up to 35 years, the AMH level continues more or less stable, and then it starts slowly getting down. And then from 38, 39 years on, it decreases a little bit quicker. So it's not that from 1 month to the other, the ovarian reserve goes down very, very quickly. But it be in between 6 months, if you have already a limit AMH, you might notice a decrease in between 6 months, 1 year, but in the end, it depends on every patient.
Okay, good to know. Thank you. Someone says that they're 37 with FSH 17.6 plus an AMH of 0.8. Will this make chances of IVF difficult?
Yes, probably it's not the best conditions for starting. AMH 0.8 nanogram or 0.8 picomole. Maybe she can answer us. But the FSH with 17, it's already higher than 10, so it's high. I would try. I would try, but I wouldn't wait too long.
Okay.
Because
And
it's chances.
yes, no, that's really good advice. And if anyone wants to speak to yourself or the team at Vida, we've popped the link in the bio, so please do head there to book a personalised consultation where you can discuss, your personalised treatment plan and what you need. We've mentioned or touched on egg donation. At what point would you advise patients to move from using their own eggs to looking at egg donation?
Well, in the end, it's the decision of each patient and of each couple. But it's true that we have some conditions that really guide us to egg donation from the beginning. Most important is the maternal age. So up from 43, 44 years, it's really, really, really difficult to get a healthy pregnancy with your own eggs. So I think from 43 years on, I would recommend egg donation. The same if the ovarian reserve is very, very low, or if you have already done some treatments that you didn't get any mature eggs or any embryos for transfer. And in the end, it depends on the condition of every patient. And there are patients who tell me, I've already done 4 or 5 cycles of IVF, but I want to continue trying. And others say, I want to try it once or twice, and if it doesn't work, I just want to change because I want to have a baby as soon as possible. So it's very depends on every patient, but I would say if you have less than 3 picomole per liter AMH, which would be 0.2 or 0.3 nanogram per milliliter, or a very low follicular count, or more than 43 years, I would probably indicate an egg donation from the beginning, or recommend. In the end, it's the patients decide.
With IVF success rates, am I right in thinking that they do go down slightly past 35, but they then spike up again before going down again. Is that right? Or is that not always the case?
No, normally it's true that with the advancing age, the chances go down. But it's not that when it's your 40th birthday, it suddenly goes down. It's more like gradually. But no, it's normally it gets stable, or it keeps stable until 35, and then it slowly starts to go down.
I tested my AMH when I was 31 and had IVF, and it was around 14. And then I tested it again at 35 out of curiosity, and it had dropped to about 7. And then I tested it again at 37, and which is how old I am now, and it had dropped to 0 point something. So that felt like quite a rapid decline from, from mid-30s over the last couple of years.
Yes, it's more or less what we can expect, but it's like very fast. With 37, you're young for having a low ovarian reserve.
Mm-hmm.
So it's not like.
Sorry, say again.
It's not like average. Not like normal. It's probably lower than for other women of your age.
Is there a correlation between your egg reserve decreasing at a faster rate and earlier menopause?
Probably yes. So it does not mean that you're going to get the menopause a couple of years after having a very low ovarian reserve. But yes, there's a correlation that a woman with a lower ovarian reserve probably get the menopause earlier than like the 50 years, which would be like standard. So this normally correlates also with the cycles. Once in the beginning you have regular cycles of 28, 30 days, then probably they start to get shorter, then probably they start to get more irregular, then they can get longer, and then they disappear.
Mm-hmm. Fascinating. Thank you so much for your time today. It's such an interesting topic. You've answered some brilliant questions. Thank you to those who've watched and joined. Please do head to our link in bio, reach out to the fantastic team at Vida Fertility Institute, and they'd be very happy to take your questions and also to consult you. So thank you very much.
Thanks to you, Lois, and I hope to see you very soon. And like you said, we are open for free online consultations to discuss every patient's history and to get to a good diagnosis for every patient. Okay. Take care.
Bye-bye, everyone. Bye-bye.
Thank you. Bye.
Bye.